नमस्ते, म दीप्ति पण्डित। आजको सेसनको मोडरेसन म र ओमजी गर्नेवाला छौँ। आजको सेसनमा हामीसँग हुनुहुन्छ अनन्त सुवेदी। हामीले उहाँसँग पहिला पनि एकचोटि कुरा गरिसकेका छौँ र बेसिक टु रुमेटोलोजी भनेर अघिल्लो पालिको पावर पोइन्ट स्लाइडमा हामी स्टुडेन्टहरूसँग सानो विषयमा चर्चा गरिसकेका थियौँ र आजको हाम्रो बेसिक अब्जेक्टिभ रहेको छ अप्रोच टु जोइन्ट पेनमा डाक्टर अनन्त सुवेदीलाई। नमस्ते सर। आज हामी
Namaskar. Thank you. I'm very glad that I am able to share my experience with you guys. And today, as we discussed, we are planning to discuss how we approach a case of a joint pain. So I'll start with some learning objective. So by the end of the lecture, I'm expecting that at least you have some idea of how to approach a case of joint pain. And we'll basically talk about how do we classify a case of joint pain, and particularly a broad category of inflammatory versus non-inflammatory arthritis. That's a basic concept on any type of joint pain. And we'll also review some of the common type of arthritis. So in rheumatology, joint pain is one of the most common clinical symptom that a patient presents with. So as a rheumatologist or as a clinician in internal medicine, you have to have a good and sound understanding on how to investigate a case of a joint pain. So I'll be doing the same thing today to give you an overview of what are the causes of joint pain and how do you approach a case of a joint pain. Now, one of the key things we need to understand is when a patient comes with a complaint of joint pain, we have to make sure it is truly a joint pain. Many of the time we think of a symptom as joint pain, but when you take a detailed history and clinical examination, at the end you might reconsider whether it's truly a joint pain or not. There are many other what we call periarticular structures that could also give symptoms similar to joint pain. So it's always very important to understand to make sure that the patient complaint is particularly related to joint pain, not the periarticular pain. In general, if a patient report pain throughout the whole range of motion, we typically think of it as an articular pain. And if the patient has a particularly localized type of pain and pain is elicited in palpation with one specific area, we think of it as a periarticular pain. And that could be originating from either tendons, ligaments, or bursa around the joint area. Now, there are some key features that will help you differentiate between articular versus periarticular joint pain. Typically, if a patient has a joint problem or articular symptoms, they usually report other symptoms, which includes morning stiffness. They report warmth around the joint area, and then some other constitutional symptoms. For example, if somebody has rheumatoid arthritis, they report of joint pain, but with the joint pain, they also have some other symptoms, particularly the morning stiffness and other constitutional symptoms like fever and fatigue. Versus a periarticular pain usually is more a localized problem. It's not a systemic problem. That's why they present either with bursitis, tendinitis, or local ligamental injuries, soft tissue injury, or bone pathology. And usually they don't have a lot of extra articular manifestations. Now, to further characterize the joint pain, we usually categorize joint pain as into two categories. One is inflammatory and other is a non-inflammatory. Inflammatory type of joint pain usually present with joint swelling. They have a significant morning stiffness. In general, our teaching is if it is the morning stiffness lasting for more than 1 hour, we think of inflammatory. And if it is less than 1 hour, it is non-inflammatory type of joint pain. And patients who have inflammatory arthritis, they also have joint effusion. When you examine the joint, you feel warmth over the joint, and then there is also a limited range of motion. When you have all of these signs and symptoms like the joint effusion, the warmth, and the limited range of motion, we typically characterize it as synovitis. So synovitis is a clinical term that we use to describe an inflammatory arthritis. Now, if you have an opportunity to get a joint fluid by arthrocentesis, if you look at the synovial fluid analysis, you will see significant amount of white blood cell count, typically more than 5,000. On the other, the non-inflammatory joint pain typically presents with more bony swelling. One typical example of such is osteoarthritis, where you see swelling, but it's more of a bony swelling rather than soft tissue swelling that you see in inflammatory arthritis. Typically, the morning stiffness is less than 1 hour, and if we have an opportunity to the arthrocentesis, typically the white blood cell count is less than 1,000 in the joint fluid. Now, I'll elaborate a little more on arthrocentesis or joint aspiration because it's a very important tool while we investigate a cause of joint pain. And if you have a chance to do a joint aspiration, it's very important that you should do it because it's very useful tool that help us classify between different groups of joint pain symptoms. Now, while categorizing the different type of inflammatory arthritis and non-inflammatory arthritis, these are the different variables that we typically use to categorize whether this is inflammatory, non-inflammatory, or even septic arthritis. And this is very important. The reason is the treatment is a whole lot different. And particularly in septic arthritis, it's very important. The time is of essence when we think of septic arthritis as one of the cause of inflammatory arthritis. Because septic arthritis, if not treated on time, it has a lot of consequences leading to joint damage. In typical non-inflammatory arthritis, when we draw the joint fluid, typically it is clear to, we call it straw-colored. The white blood cell count is still present, but less than 2,000 usually. And then usually the leukocytes is the predominant cells and gram stain is typically negative. Versus in inflammatory arthritis, the joint fluid is usually yellowish color. And then typically the white blood cell count ranges from 2,000 up to 50,000, depending on what the cause of the inflammatory arthritis. And predominantly it is leukocyte predominant white blood cells. And gram stain is typically negative. Now, in the septic arthritis, due to different type of infection, typically there is significant increased amount of white blood cell count. And typically we think of septic arthritis if the white blood cell count is more than 50,000. And predominantly it is the leukocytic predominance. And the gram stain is variable depending on what the cause of the septic arthritis. So it varies from 30% up to 80%. So just having a culture negative does not typically rule out that this is not a septic arthritis. There are a few other clinical tools that we have to use, including blood cultures and then other source of infection to diagnose whether this is septic arthritis or not. Now we'll categorize, now we talk about the inflammatory versus non-inflammatory. So we'll talk about further classification of an inflammatory arthritis. Now, typically we categorize them depending on how many joints are involved. One is called monoarticular if single joint is involved. And some of the common cause of monoarticular inflammatory arthritis include infection, gout, and pseudogout. Now, in the later topics, we'll discuss more on individual condition, but these are the basically three most common cause of monoarticular inflammatory arthritis. Now, the second category is called oligoarthritis. Typically, 2 to 4 joints are involved in oligoarthritis, and these are the common causes, including ankylosing spondylitis, reactive arthritis, IBD-associated arthritis, and psoriatic arthritis. And polyarticular inflammatory arthritis, typically more than 4 joints are involved. And sorry for the typo. It includes rheumatoid arthritis, psoriatic arthritis, and connective tissue disease-related arthritis, which could include lupus, systemic sclerosis, or Sjogren's. This is a very handy table that helps you organize your thought when you see a patient with arthritis, depending on how many joints are involved. This is a general guideline. Not every patient follows this guideline, but at least you should have this outline in your mind when you make your, when you formulate your differential diagnosis. Now, other category that we discussed, the non-inflammatory, the typical one you might have seen quite a lot that includes osteoarthritis, the most common non-inflammatory arthritis. And then the other category includes the internal derangement, including injuries like either meniscus injuries or tendons or ligamental injury. And they usually present with non-inflammatory arthritis. Now, I'll give you a little bit of overview starting with the osteoarthritis, which is one of the most common form of non-inflammatory arthritis, and usually patient presents with chronic joint pain for several years. It could be the monoarticular, particularly the knees, the hips, or the low back are the most common areas, and it could be oligoarticular or even polyarticular. Typically, there is a form of arthritis called erosive osteoarthritis, which typically causes polyarticular arthritis involving the hand joint. And when you examine, you typically find non-inflammatory signs that we just discussed earlier. That includes bony swelling, not a lot of warmth, and very minimal effusion. Those are the typical signs of non-inflammatory arthritis. Now, we'll typically see these are the different findings that we find in the X-ray. So the X-ray is an important tool in the diagnosis of osteoarthritis. Osteoarthritis is typically a clinical diagnosis, but you could use X-rays to support your clinical impression. And when you order an X-ray, these are the few things that you will be looking for if you think this is osteoarthritis. That includes joint space narrowing, osteophytes, basically meaning extra bone formation in around the joint area. And then there is some irregularity or sclerosis in the articular surfaces. I will go over those findings in some of the X-rays that I'll be showing later. And then you could also find subcortical cysts. So these are the 4 cardinal features of osteoarthritis. So this is a normal X-ray. So you could appreciate there is a good joint space between the two articular surfaces. This is the your femur, and then the the tibia. You have nice articular surface. They are very smooth. And you don't see any bony outgrowth at the joint margin. So this is a normal X-ray of your knee joint. Now, let me see. So this is a X-ray of an osteoarthritis. So you could see the difference. Now, one particular thing we first discussed was joint space narrowing. And typically these are asymmetric, meaning if you look at the 2 compartments, the medial and lateral compartment, there is asymmetric narrowing of the joint space. So that is one of the typical features of osteoarthritis. And you could also see some bony projection on the sides, on this side here, and then this side here, that is called osteophytes. So that is one of the typical features of osteoarthritis. And then other thing we discussed was the sclerosis, meaning extra bone formation. So if you look at if you compare 2 X-rays, this has more white or more radio opaque. So that's a sign of extra bone formation, and that is called sclerosis in the joint margin. That is another typical features of osteoarthritis. Now, this is the label on what we just discussed. So it includes the osteophytes at the joint margin and irregularity of the bony margin, bony surfaces, and then joint space narrowing and osteophytes. Those are the typical features of osteoarthritis. And this is an example of the knee, but it's similar to most other joints, including hip or other joints that are involved with osteoarthritis. Do you guys have any questions in the X-rays that we need to discuss more? We can discuss at the end if you have any more questions from the chat room. Now, this is another features of osteoarthritis that involves the hip. And this is a normal hip X-ray showing the femur, the head of the femur, and then the joint space. And this is a normal joint space. Now, compared to the osteoarthritic hip, you could see there's an asymmetric joint space loss. This area is a little bit normal. And in this area, in the medial side, there is a joint space loss. And you could also see the sclerosis in the joint margin. That is another typical features of osteoarthritis. And you could also see some osteophytes here. And then these are what we call the cyst, the cyst under the joint space. Now, this is another example. So I'm showing different part of the body that shows different type of osteoarthritic features. So this is an example of osteoarthritis involving the hand joint. And typically this variety is called erosive osteoarthritis. That's a typical variety of osteoarthritis. Now, if you could see, now let me see if I have a normal joint. Sorry, I forgot to add the normal joint. So if you see, there is a significant loss of joint space between the 2 bones in your PIP joint. Or sorry, DIP joint, and same is in the PIP joint, and same is in this joint. So there's almost no joint space there. There is some preserved joint space here, but if you look at the third finger, there is no joint space here. So that is another typical features of osteoarthritis. And in hand, we also described some of the finding called Heverden's nose. That basically is a osteophyte present in your DIP joint. And if there is osteophyte in the PIP, we call them the Bouchard node. So those are basically extra bone formation in hand osteoarthritis. Now, the spine is also a common area where you could get osteoarthritis, usually present with low back pain, chronic low back pain, especially in the elderly population, and is a similar pathophysiology of what you find in other forms of osteoarthritis. Now, this is a normal spine X-ray. Now, we'll compare the normal spine X-ray with the osteoarthritic. Sorry, this is osteoarthritic. I think I forgot to add the normal X-ray. Now, with the same thing we are seeing, these are your vertebral end plates, and you could see osteophytes here. So these are the bony projection that are coming out of your bone, the vertebral plate. So that is one of the signs of osteoarthritis. Now, if you look at the other X-ray on your right, these are the normal joint space. This is a normal joint space, but this area, there is significant narrowing of the joint space between the two vertebral plates, and that is one of the signs. And there's also limited joints, the disc space, and then also sclerosis in between the end plates. That is another typical features of osteoarthritis involving the spine. Now, that is the overview of what we find in osteoarthritis and what are the typical radiological features. Now we'll switch our gear and then talk about inflammatory arthritis. And we'll talk about some of the common form of inflammatory arthritis. And now you remember this characterization or classification of the inflammatory arthritis into 3 varieties, depending on how many joints are involved. And these are the common differential diagnosis based on the number of joints involved. So we'll go over individual disease conditions. Now, one of the type of inflammatory arthritis is septic arthritis. Now, they usually present with features of inflammatory arthritis, and it could be either monoarticular or polyarticular. Typically, it is monoarticular, but polyarticular is relatively rare, but that could happen particularly in the non-gonococcal form of inflammatory septic arthritis could also present with polyarticular form. And there are basically 2 forms called non-gonococcal inflammatory infectious arthritis or septic arthritis, particularly prevalent in older patients and patients who already have a damaged joint, like osteoarthritic joint. And the gonococcal arthritis is more common in sexually active young male or females, and typically it happens in a normal joint. And typically patient present with fever as a constitutional symptoms, and then when you do a synovial fluid, sorry, I think there's a typo. Typically the white blood cell count is more than 50,000 is the typical of a septic inflammatory arthritis. And culture is positive in almost 30 to 80% of the patients. And this is a very important difference diagnosis because the time is very important in treatment of the septic arthritis, like early initiation of antibiotic and joint lavage is very important to avoid long-term joint damage. Now, the other variety of inflammatory arthritis is called gout. And it is due to the main pathophysiology is the uric acid crystal deposition in the joint. It could be any joint, including knees, one of the common one, ankle is other, and few other joints. And typically they present with either monoarticular or oligoarticular. That's a typical of a gouty arthritis. And they typically present with acute attacks. All of a sudden they start, they present with acute symptoms. And even without treatment, they usually resolve in the next 2 weeks or so, even without treatment. And usually when you do a joint fluid analysis, it shows inflammatory arthritis with presence of uric acid crystals. Now let me move my... So other form of inflammatory arthritis is called pseudogout. The name suggests it's similar to gout in clinical presentation, but the crystals is different. In gout, it is urate crystals. In pseudogout, it is calcium pyrophosphate crystals. Typically happens in older age males. That's a typical, and happens in patients who already have joint damage because of osteoarthritis. And it could present with either few joint as a pattern of oligoarticular, or it could be a monoarticular arthritis. And they also have an acute attack, and they also have a chronic form where people have arthritis for a long period of time compared to gout, which usually typically is not a chronic form. And in X-ray, there is a typical feature that you see called chondrocalcinosis, basically meaning the calcium deposit in the cartilage. And I will show you a picture of the X-ray of a chondrocalcinosis. So this is a typical radiological features of chondrocalcinosis. Now you could see this is a white, fine white material in between the joint. Typically you don't see those radiodense material, but this is a sign of chondrocalcinosis, and that could indicate this is a pseudogout. Now, not all people who have pseudogout in the X-ray that suggests this is, not all people who have chondrocalcinosis in the X-ray does not always indicate pseudogout, but if patient presents with inflammatory arthritis and if you see chondrocalcinosis, that indicate it is likely pseudogout, meaning not all people are symptomatic even with chondrocalcinosis. Now, the other form of inflammatory arthritis is rheumatoid arthritis. Typically, it's a chronic arthritis, and by definition, the joint symptoms are for more than 3 months, and they usually present with symmetric, meaning bilateral hand or bilateral feet involvement, and they present clinically with inflammatory arthritis. And one of the key features of differentiating between rheumatoid arthritis and the other form of inflammatory arthritis is RA does not affect DIP joints or the back. So if you have a patient who have DIP involving, that is likely psoriatic arthritis rather than rheumatoid arthritis. And rheumatoid arthritis never affect the back joint. So that is one of the typical features that help you differentiate between rheumatoid arthritis versus other form of inflammatory arthritis. Typically, they have serology positive, either rheumatoid factor or a CCP. And they typically have joint erosion, that is a sign of joint damage due to inflammatory arthritis due to RA. Now, this is a good example of a joint erosion. If you look at the X-ray on your left, you could see a chunk of the bone is missing. That's what we call marginal erosion. That's a typical sign of rheumatoid arthritis. Now, the psoriatic arthritis is another variety of inflammatory arthritis, and similar to RA, it is a chronic form of arthritis, and it could involve either few joints or multiple joints. And sometimes it's very difficult to differentiate between psoriatic arthritis and the rheumatoid arthritis if they have a polyarticular involvement. And in general, they have more of asymmetric joint involvement compared to rheumatoid arthritis, meaning you could have one part of your body involved, not the others. That is not typical for rheumatoid arthritis. And most of the patients, many of them will have psoriasis. Some people, like around 25%, they start with psoriatic arthritis and later on develop skin rashes. That is also seen, but many of the patients usually have psoriasis. And it's very important to do a good skin examination if you think somebody has psoriatic arthritis. And many of the patients will have some nail changes that include pitting, onycholysis, that could indicate underlying psoriatic arthritis. Now I'll show you some pictures. So this is a DIP joint that shows a significant joint erosion in the DIP joint, and then sometimes we call the pencil in the cup. That's a typical you will see in your exam, this type of X-ray, which indicates psoriatic arthritis. Now, the other variety of inflammatory arthritis is called ankylosing spondylitis. And typically, these are young patients who present with chronic low back pain and significant morning stiffness. And if they have a peripheral arthritis involvement, typically they have an asymmetric form of arthritis. And common joint involved include hip and shoulders, compared to RA, which has more small joint. The Ank spon usually affect more of a bigger joint. And typically, lower extremity joints are typically affected. Now, this is a radiological example of ankylosing spondylitis, and this is a normal SI joint. And if you look at the SI joint X-ray, it's a little bit difficult to learn. So the more you see, the more better you become. So always make a habit of seeing your own X-ray. So this is a normal SI joint, and particularly in Ank spon, usually the lower part of the SI joint that is typically affected. You could see normal joint space. So this is a normal SI joint. And if you compare to the abnormal one on your right, you could hardly see any joint space. So this is a fused sacroiliac joint, and that is secondary to ankylosing spondylitis. Now, there is another variety of inflammatory arthritis called reactive. The name it suggests it is in response to some form of infection. Typically, it could be GI or genitourinary infection or UTIs. People could have a prior history of either diarrhea or urinary tract infection, and then a few weeks following those infections, they could present with arthritis, conjunctivitis, and urethritis. And there is a typical syndrome we call Reiter's syndrome, and there is a mnemonics. They say can see, can pee, and can't. What I almost forgot. Can see, can pee. Can climb a tree. So can climb a tree because of arthritis. Okay. That is a mnemonic that you could use to think of Reiter's syndrome. And they usually present with asymmetric oligoarthritis, meaning less than 4 joint involvement. Typically, the reactive arthritis is a self-limiting problem where it doesn't have a chronic condition, but rarely, like 20% of people could have a chronic arthritis that lasts even for several years. But typically, most of the patients recover from the arthritis in the first 6 months of the problem. Now, I give you an overview, so I'm just recapping on what we quickly discussed. So we characterized joint pain into 2 forms. One was the inflammatory, and the other one was the non-inflammatory. And in the inflammatory, we talk about monoarticular, oligoarticular, and polyarticular. And in monoarticular infection, gout and pseudogout as the most common one. And in oligoarticular, we talk about ankylosing spondylitis, reactive arthritis, IBD associated, and psoriatic arthritis. And in the polyarticular form, rheumatoid arthritis is one of the common, psoriatic arthritis, and the connective tissue disease related arthritis that include lupus related arthritis, scleroderma, or the Sjogren's. Now I'll stop there, and then I'll have you guys ask me some questions. Now you can, the moderator can, I think, collect the questions, and then we can go over if you guys have any.
Hello again, sir. There are some questions in the chat box, and I would like to ask the questions to you.
Sure.
Okay. Ask, are there tibial spikes, osteophytes as well? This must be question to osteoarthritis, maybe.
Tibial osteophytes, you mean?
Yes, sir.
Okay, let me go to the X-ray. Now, if you look at the, this is a good example of the osteophyte. So you could see here, let me make it a bigger one here. So the osteophyte could happen, typically they happen in the marginal area of the joint. So the margin that we're talking is, this is a good example of a big osteophyte here. And this is another example of a big osteophyte in the femoral area. This is more in the tibial area. Really, sometimes you could find in the tibial plateau too, but it's very difficult to see in this one. But this is a very good example of the osteophytes. And typically, the osteophytes are usually at the end of the bone, called joint margins. Now you could compare with this is a normal X-ray, and then this is an osteoarthritic X-ray, and this is just the labeling of different abnormal findings.
So the tibial spikings are not osteophytes; they're separate entity.
In this one, I don't see the tibial spiking. I think they label it here, but it's very difficult to see in this one. Maybe this is the osteophyte, but basically the osteophyte, the basic pathophysiology of osteophyte formation is extra bone formation. You could have any area of your bone. Now, even the sclerosis is also a sign of extra bone formation. And that is a response from our body. When there is not enough cartilage, the bone and bone come together, and then the bone doesn't like it and they make extra bone. So osteophytes is basically a sign of extra bone formation. That's a typical feature of osteoarthritis. Compared to inflammatory arthritis, usually there is erosion. There is no sclerosis. So erosion is a typical feature of inflammatory arthritis. So if you see sclerosis, it is likely non-inflammatory. If you see erosion, it is most likely this is an inflammatory arthritis.
Another question is from Dipti. What is the significance of RF?
So the rheumatoid factor, it's one of the, now in diagnosis of rheumatoid arthritis, if you look at the ACR, the American College of Rheumatology classification criteria, so we put different value for different parameters. One is, the most important is you have to have a history of chronic inflammatory polyarthritis. Now from there, even psoriatic arthritis could also cause similar symmetric inflammatory arthritis. So one of the way of differentiating between psoriatic arthritis versus rheumatoid arthritis is those serology. Now, by definition, rheumatoid arthritis is an autoimmune condition, meaning your body make autoantibodies. So rheumatoid factor is one of the autoantibodies that is made by your immune system against the joint tissues. So the rheumatoid factor usually help us differentiate between whether this is psoriatic arthritis or ankylosing spondylitis versus rheumatoid arthritis. Now, the rheumatoid factor is not a specific test. It's a sensitive, but it's not a specific, meaning some other condition. If you have infection, you could have rheumatoid factor. That's why it's not a very specific, but a sensitive test. Now, compared to other one that we discussed, the CCP, that is a very sensitive test. Sorry, very specific test. If you have a CCP positive, it is more likely than not that this is rheumatoid arthritis. But rheumatoid factor, it could be positive from many other conditions too. Let me see if I was just trying to recap the rheumatoid arthritis. Yep, so you have serology positive, either you could have RF or CCP, but CCP is more specific than rheumatoid factor.
सर rheumatoid factor पठाउँदाखेरि केही कन्क्लुजन निस्किदैन भने हामीले पठाउनुको कारण के हुन्छ त नि?
So help गर्छ if you see somebody who have inflammatory arthritis, now you are not so sure whether it is RA or not. If the RF is positive, it is more likely this is rheumatoid arthritis. Now there is a variety of rheumatoid arthritis called seronegative, meaning you have a clinical features of RA, but the serology is negative. Now, there is some prognostic importance of the serology too. People who have positive serology, either rheumatoid factor or CCP, they tend to have more severe disease, meaning more joint damage. That's why we use this for both diagnostic and for prognostic importance as well.
Okay. Now we have another question, sir. Is there any reason why some disease involve specific joint and spare others? Joint ko anatomy le kehi farak parcha ki pardaina?
So that's a very good question. I think we have very limited understanding of why one joint versus other. But in RA, what happens is RA is a problem where you have synovial inflammation, right? So it affects synovial joints. Now you have synovial joint in multiple areas, including your hand, knees, and then the feet. So RA typically affect the synovial joints. Now the psoriatic arthritis, we don't know yet why is it asymmetric versus the RA, but in psoriatic arthritis, the pathophysiology is a little bit different. Now we'll talk more on the typical feature of psoriatic arthritis later. So there is an entity called enthesitis. You might have heard or not. So enthesis is basically a tissue, or it's an area where the tendon goes into the bone. And in psoriatic arthritis, inflammation starts in the enthesis. So it's an enthesial inflammation. That is the initial process. And from there, it becomes inflammatory arthritis. Versus RA, it is more of a synovial inflammation. That's why it starts in the joint, within the synovium. Now in ankylosing spondylitis, it's a predominantly disease of axial skeleton, especially spine, hip, and then the shoulder. So it's typically a disease of the axial joints.
Did you get it?
Yes.
Okay, thanks. Sir,
Yeah,
there is
yeah.
a question from Sabine. Sir, why inflammatory arthritis is more common in female than male?
Now it's an area where there is still a lot of research ongoing. We don't have a definitive answer why, but there is a lot of genetics involved, but I don't think we have a clear understanding of why. Now there is also thought of, there might be some hormonal influence, like estrogen might be causing some pro-inflammatory cytokines that might be causing the autoimmunity, but still I don't think we have a good understanding of why.
The answer is still questionable.
Yeah, the answer is still questionable. Yeah. Now there's a lot of research now. People are looking at the biology, like why females get like lupus in general, why male get more ankylosing spondylitis. But now there's a lot of, most likely there is some genetic role, but I don't think the clear answer, we haven't had a good understanding of why.
Okay, sir. Okay. Do clinical examination, SLRT make any diagnosis in sacroiliac spondylitis?
The short answer is no. So the SLRT is a very non-specific finding. So anything could cause SLRT positive, like including disc herniation, even if you have osteoarthritis. So it's not a specific test. It's a very non-specific test. So you should not be relying on SLRT. Now for ankylosing spondylitis, one of the most important is history. Now, if a young male comes with long history of chronic low back pain, that is the first clue of the disease. Now, the next step is you try to understand whether this is an inflammation problem or not. So you get CRP ESR. And now we also use HLA-B27. So that is a gene marker of ankylosing spondylitis. This sometimes becomes useful, but sometimes it may not be, because not all people who have ankylosing spondylitis will have a positive HLA-B27. But if you look at the classification criteria, the HLA-B27 is one of the features for classifying as ANKSPON. Now, the next step becomes X-ray. So if you see sacroiliitis or joint fusion in the X-ray, that is a very good, that's a very specific tool to make the diagnosis. But one problem with that is typically the joint fusion happens very late. Now, our goal is to diagnose early. So if you rely on the X-ray, we will be diagnosing somebody who have ANKSPON for more than 10, 20 years. So that's not helpful. So that's why these days we do a lot of MRI of the sacroiliac joint. So if you suspect sacroiliitis, I think MRI is a very important tool. So basically history, inflammatory markers, ESR, CRP, X-ray of the SI joint, and then followed by HLA-B27 and the MRI. So those are the different way we use to make the diagnosis.
So besides X-ray, what is the most investigation sent in rheumatology?
Now, it depends on what type of rheumatic disease we are talking. In rheumatoid arthritis, I think the serology X-ray, I think that is always enough. We most of the time don't do MRI. MRI is not needed to make the diagnosis of rheumatoid arthritis. So that's an overuse of an MRI. So MRI is, we never use MRI to make a diagnosis of rheumatoid arthritis. Now in ankylosing spondylitis, we use X-rays, your ESR, CRP, HLA-B27, and then MRI. So in ANKSPON, MRI is quite helpful because we don't have a good tool to make the diagnosis compared to rheumatoid arthritis. Now in psoriatic arthritis, it's basically a clinical diagnosis. Clinically meaning somebody who have psoriasis and who comes with inflammatory arthritis, and that is, you could easily make the diagnosis that this is psoriatic arthritis. Now, all psoriatic arthritis is not very clear. Typically, people who have just the enthesitis, you may not see a lot of signs and symptoms of inflammatory arthritis. So that sometimes become a tricky, but it takes time to make the diagnosis. So that's why the psoriatic arthritis sometimes get delayed diagnosed because of the lack of good clinical signs and symptoms. Now, in septic arthritis, on the other hand, the arthrocentesis is the most important. So if you think somebody has septic arthritis, you must do arthrocentesis because that's very important. For one is for diagnosis and other is for culture. And then based on the culture, you could give the patient the appropriate antibiotics.
Okay, sir. Can I ask you another question?
Sure, go ahead.
Next question. Yeah. Season Kharka has asked in rheumatoid arthritis diagnosis, either it is RA and CCP or RA or CCP. I think it means
RF or CCP. You could have either. Now the CCP is a little more expensive in Nepal. So if you just want to do RF, that's okay for the diagnosis. But for prognostication, CCP is also important. And the reason is people who have both seropositive CCP and RF, they tend to have more severe disease. So you have to be a little more aggressive on how you treat. Like typically when I see patients who have both CCP, RF positive, I usually start them with methotrexate because they tend to have more severe joint damage down the road. That's why we become more aggressive. But if somebody doesn't have CCP positive, RF positive, now methotrexate is the first line, but sometimes people are very reluctant to go on methotrexate because of the side effect. They are scared. I give them an option of either Plaquenil or hydroxychloroquine. But the ACR guideline says you should use methotrexate as the first line. But if the patient doesn't want to take methotrexate, if they have a seronegative, then I'm okay starting Plaquenil in the beginning. And then if they don't respond, then I'll switch to methotrexate.
Okay, there is a question about HLA-B27.
Yeah.
Is HLA-B27 more significant in ankylosing spondylitis, or is it rheumatologically related?
No, it's more for angspon. So in angspon, the HLA-B27 is a gene marker for angspon. So people who have HLA-B27, they tend to have ankylosing spondylitis. So it's used as one of the diagnostic tool. It's not just helpful for rheumatoid arthritis, but sometimes people who present with polyarticular inflammatory arthritis, like they have arthritis in their hand, then feet, and then they don't have serology. Like if you ask RF, CCP, both are negative. Now they could have there is a variety called peripheral form of ankylosing spondylitis. So in that case, if you find HLA-B27 positive, it is more likely this is angspon with peripheral arthritis. So in that case, you could use it, but it's not the typical tool we use for rheumatoid arthritis. And it's expensive. So
Another
I think
question
you should
is
not
from
order like HLA-B27 for everybody, because it's an expensive test and it may not have a lot of value if you are thinking of rheumatoid arthritis. So that's why the most important is when you examine a patient, make a habit of making a differential diagnosis. So number one, think of, oh, this is most likely RA, this is most likely psoriatic arthritis, this is most likely reactive arthritis. And then if you have angspon in the bottom of your list, you could first do those tests and then have a patient come back, follow up. And then if you are not getting the clue, then you can order the HLA-B27 as a next line.
Another question is from Deepa Budathuki. It's gonococcal arthritis is involved in young sexually active individuals. So does that mean individuals should be involved in sexual activity or not?
Can you repeat your question? I didn't get the last part. Sorry.
So does that mean the individual who has gonococcal arthritis should be involved in sexual activity? I think that's the question.
Typically, yeah. If you suspect gonococcal arthritis, you should always take a good sexual history. That is very important. So typically, they will have a history of like unprotected sexual encounter at some point before the presentation of septic arthritis.
But after they get one, can they be sexually active or not?
They could, yeah. After I missed the question. So after they are treated, now they need treatment with antibiotics, and after antibiotic use, I think that doesn't prevent you having a further sexual activities. Now, some people, even after treatment with antibiotics, they could have a little bit longer course of the reactive arthritis. Typically, by 6 months, most people do recover, but there are variety, like around 25%, they could have a chronic arthritis. But it's not an infection. It's more of a reaction to the bacteria that cause the arthritis. So it's not an infection. It's more of a reaction on how our immune system react to the antigen of the bacteria.
Regarding a sexual activity, it depends on if there is an active gonorrhea or not, if that is being
yes,
or
yep.
not, right? Yeah. And you want to use precaution if you really want to.
Absolutely, yeah. That is always important. I think they will mute us. I think you are muted.
Okay. Okay, Asmita asked questions to everyone. Is there any relation between RA and vitiligo?
Now, both are autoimmune condition, but I don't think they are interrelated. Now, vitiligo is more common, more so in autoimmune thyroid disease, but not so much with the autoimmune, like rheumatoid arthritis or other autoimmune arthritis. But it's an autoimmune condition that affects your melanin. That is I think the autoimmune, the immune system attacks the melanin, the pigment making cells that cause the vitiligo, but it's not unrelated with rheumatoid arthritis.
Oh, okay.
And so far, the last question is from Pramila Adhikari, who asks, is there any relation between food we take and arthritis? What food should we avoid to decrease arthritis in female?
So that's $1 billion question. And the reason is we don't have a good answer. And there's a lot of active research in that area, like diet and then autoimmune condition. Now, there was a recent paper that came in the last year. They looked at people who presented with joint pain, like arthralgia that we call. They didn't have all the arthritis, like they didn't have any features of inflammatory arthritis, but they have arthralgia, and they have a seropositive, either CCP or RF, and they were smokers. And they look at that population because smokers who have seropositivity, they are at very high risk of having rheumatoid arthritis. So they look at the high risk population, and then they randomize into two groups. One is the usual diet, and other one is the Mediterranean diet. Now, let me tell you a little more about what is the Mediterranean diet. So the Mediterranean diet consists of a lot of vegetables, nuts, olive oil, and less of a fat. So that is a typical Mediterranean diet. And when they followed them for almost like 2 years or so, in 2 year period, there was a significant less incidence of rheumatoid arthritis in the Mediterranean diet group. So that suggested that there is a role of some diet in autoimmune condition in the high risk population. Now, in low risk population, I'm not sure whether changing diet is going to significantly change your risk of having rheumatoid arthritis, but if you are in a high risk population like smoker or family history, or you have arthralgia, and I think making dietary changes might be helpful. But I think the most important in RA is smoking. I think smoking is a very well-known risk factor for rheumatoid arthritis.
What about supplements like chondroitin?
I don't think we have enough data to support supplement. Now there is a big wave in the US of using turmeric. Now what we call besar in Nepal, right? So there's a big, like there are pills of turmeric. So you guys are already protected if you think of supplements. So I think turmeric is known to have some anti-inflammatory property, and there is some good data to support. But in itself, it may not be enough. But I think if you add turmeric with other treatment options, I think that's okay to use.
But chondroitin and glucosamine, they have no
yeah,
role.
I don't think we have enough good data to support use of those. Now, this is a big time. It's a business of using chondroitin sulfate. I don't think we have good data to support the use of those. So it's not helpful in osteoarthritis.
So collagen supplement khaदाखेरि?
No, I don't think that we don't have enough scientific data to support those supplements.
Basically त्यसो भने joint healthy राख्नको लागि Mediterranean food use गर्नु पर्यो जुन महँगो पर्न सक्छ नि त.
So correct गर्छु सबैले हैन, people who are at risk of rheumatoid arthritis. So not everybody. But I think our diet in Nepal is very good. We eat a lot of fresh vegetables. We eat a lot of organic, like you guys grow a lot of things at home. So our diet is, and that's one of the reasons why we don't have a lot of rheumatoid arthritis in Nepal. Like in Nepal, compared to the US, the incidence is quite low. And that is because of the good diet.
I have a question about joint health. About young मान्छेहरूले कस्तो एक्टिभिटिजहरु अभोइड गर्ने अथवा like what can we do to keep our joints healthy for young people or older people?
Now, there had been like a lot of people, like especially patients ask me like, oh, if I'm an athlete or if I run, does that increase your risk of having osteoarthritis? And the short answer is no. Now, if you are a professional athlete, if you have injuries, that does increase your risk of osteoarthritis in the future. But if you haven't had any injuries, just like running, jogging, regular activities, I think that is better. And the reason is it maintains your joint mechanics, and then it maintains the alignment. So it's good for even reducing your risk of having osteoarthritis. So regular exercise is very good for any type of arthritis. But I think the injuries is the one that increases your risk of having osteoarthritis.
So high impact or low impact exercises?
I don't think, yeah. I think as much as you could do, as much tolerated.
Morning stiffness को लागि के exerciseहरु हुन्छ कि हुँदैन सर?
About you, it depend on what type of arthritis, like osteoarthritis, rheumatoid arthritis. But typically, typical your treatment भन्ने त छैन, तर त्यो चाहिँ अब कति severe symptoms छ त्यो अनुसार हो अब treatment के गर्ने भन्ने चाहिँ अब usually as you move, most of the arthritis like either osteo or rheumatoid, it get better as you continue to like do physical activity during the daytime.
अनि फिजियोथेरापीको रोल कतिको सिग्निफिकेन्ट छ?
There is important role, particularly in rheumatoid, in osteoarthritis. Now there was a clinical trial that compared physical therapy, supervised physical therapy, comparing to joint injection, like of steroid. And it showed that even the physiotherapy is much better, even better clinical efficacy than the steroid injection. So it's a good modality of treatment. Now in osteoarthritis, we don't have any major treatment options. So you use either safe pain medication, then physical therapy is the next option. And then joint injection is another option to at least decrease your symptoms, but that's a short-term solution. It's not a long-term. So physical therapy has multiple benefits. One is it strengthens the muscles around the joint. So it has a lot of good support for the joint. That is good for the osteoarthritis. And it also relieves some of the pain and improve your quality of life. So the more you move, the better it is for your overall quality of life.
So treatment modality को हाम्रो main objective चाहिँ के हुन्छ? Disease
More symptomatic treatment. Osteoarthritis is predominantly symptomatic. But rheumatoid arthritis is a different topic, but osteoarthritis is predominantly symptomatic, and using safe pain medication. I think that is very important because sometimes people overuse NSAIDs like ibuprofen or other NSAIDs. So it's very important, particularly people more than 65. You have to be very cautious to counsel them that because many people take over the counter, right? Without asking, without telling you. So it's always important to ask how much NSAIDs they are taking, particularly people who have risk factor, like who have history of ulcers, who have history of heart disease. So it's very important to get a good history of how much they take of the NSAIDs.
Rheumatology wonder drug भन्ने कुनै छ कि छैन सर?
Now I think in the last 20 years, rheumatology has seen such a boom in treatment options, particularly rheumatoid arthritis. So we have excellent options. Now, if you ask me if you ask me a name of a medication, I will call TNF inhibitors. Now, you might have heard or not. So for rheumatoid arthritis, the TNF inhibitors has been I think that has been a huge asset in the treatment option for rheumatoid arthritis. Now, there's a new group of medication that was recently discovered, like in the last 5 years. They are called JAK inhibitors. Now, in Nepal, you do also find that, like Geljan is one of them. That's another game changer. The reason is they are pill form of rheumatoid arthritis medication. Otherwise, most of them are injectable. So the Geljan is a pill form, and that's very easier to take. And there is also not a higher risk of having TB problem back in Nepal. So that is also a good option for Nepal, Geljan. It's called JAK inhibitors. Now we'll talk more down the road when we talk about rheumatoid arthritis in that group of medication.
Sir, अनि orthopedic को joint pain approach र rheumatology को joint pain approach मा के difference छ?
Now I have to go back and remember my days when I was rotating with Dr. Bascota. Approach, I think most important approach for joint pain is the diagnosis. I think that is I think either you go to an orthopedic surgeon or you go to an internist. I think the first most important thing is to make the diagnosis, right? Because in Nepal, there are not a lot of rheumatologists. So either the patient goes to either orthopedist or it will go to an internist. And most of the time they will go to orthopedist. So they have to have an approach of, is it inflammatory arthritis or is it non-inflammatory? If it is non-inflammatory, it's their area of expertise. If it is inflammatory, then they have to refer you to either internist or a rheumatologist. But I think the key takeaway from my talk today is make sure you guys understand what is inflammatory arthritis versus non-inflammatory, because that's a key that help you make a lot of diagnosis.
Non-inflammatory मा NSAID use हुन्छ कि हुँदैन त सर?
Usually the pain we're talking about the pain management. So you start with Tylenol. You call paracetamol in Nepal, right? Paracetamol you could use as a safe option, and the next option is NSAID. So any of the NSAIDs you could use for pain control.
And thank you so much, Dr. Ananta and Dipti Pandit, for making this happen today. अनि आजको एकदमै रमाइलो पनि भयो अनि एकदमै इन्फर्मेटिभ मेन की पोइन्ट चाहिँ
मैले पावर पोइन्ट पनि दिदीलाई मैले शेयर गर्दा छु, तिमीलाई पावर पोइन्ट चाहियो भने युज गर्दा हुन्छ?
Yes.